afternoon, ladies and gentlemen. We are not just yet ready to start, but I wanted to make a quick announcement to let you know that one, we're grateful that you are here, and two, we would be grateful if you would share out the link with those who are not able to attend. So for those of you who are in the St. Luke's WhatsApp group, since all of you except our Keynote is in the St. Luke's WhatsApp group, it's okay, you can confess it's church. If you're not in the group, I'm happy to add you. Those of you in the group, the link is in the group. Please send it out, not just to the members of the church, but others who you think would benefit from today's presentation. So I'm giving you permission to break out your phones, to use WhatsApp. This is the only time in church that you can use WhatsApp. Find the link and send it out. Father Kamar, you did it already. That's why you're not doing it now. Okay, good. Checking, making sure everyone's getting it. I see Nola, she got the assignment. Great. Yes. I see sent it out. I see Christine doing it. That's great. Lovely. So we will begin in just a few moments. We got word that there are one or two persons stuck in traffic, so I'm going to ask for 3 more minutes. And in the meantime, as I said, the only time you're allowed to use WhatsApp in church is to share out the link. Thank you so much, everyone. Hello, good evening. Please feel free to join us. All right. Wonderful to have you. Please have a seat. Okay, ladies and gentlemen, without further ado, we are ready to start this evening's proceedings. Let me start by welcoming you all to this lecture series today. In case you don't have a program, everyone has a program. If not, I'll happily bring one to you. We are here for the, I don't do math well, since 2004 to now, lecture series. That's 20 years? Oh my goodness, welcome to the 20th annual St. Luke's Lecture Series. Give yourselves a round of applause. Thank you so much. You have made it, you have braved the traffic, and you have braved the traffic, and you have made it here. And we are grateful to have you for this very important lecture series. I'll let you know more about it. Many of you are familiar with the series already, but I will speak to it further later on. But I just want to be able to say that we are going to have a remarkable experience where we learn from each other, and we can then take the lessons that we have out in this beautiful health month that St. Luke's is celebrating. Please allow me to acknowledge all the wonderful people who are here. I will start with those on the program and then move to all of you in the audience. Thank you so very much, Archdeacon Patrick Cunningham, for hosting us here at St. Luke's. We are grateful to you. And of course, Reverend Kemar Prendergast, our Assistant Rector, who is doing great work. Later on. With the acknowledgements out of the way, and you know why we're here, I'm going to give some housekeeping matters before we move forward. From this point, unless you're specifically asked to, I'm going to ask you not to use your phones, because I know you already did what you needed to do, as we give our presenter and everyone who will be making a presentation our full attention. And we ask that if you have any questions, please keep them to the end of the presentation, because we will have a lively discussion. With all of that said, I know that we cannot have any function here. I know that we cannot do anything in life. I know that as God-fearing people, we don't want to move any further without having a blessing. And to give our blessing today at this 20th annual lecture, please welcome Father Kemar Prendergast. You can applaud him. We're in church, but we're not at church, yes? Yes.
Thank you. The Lord be with you. Let us pray. Loving and compassionate God, we gather here this evening in your presence, recognizing your grace and wisdom in all aspects of life, especially in our moments of pain and suffering. As we are about to dive into this lecture series under the theme, Pain, the Fifth Vital Sign, we are reminded of the human experience of pain, both physical and emotional, and the need for understanding, compassion, and healing. Lord, we pray that you'll lift up and bless our presenter, Dr. Stacy Davis, whose expertise and dedication have brought us together for this important discussion. We ask that you will bless their words and insights, that they may enlighten and challenge us to see pain in its many dimensions and to respond to it with greater empathy and care. So open our minds and hearts that we may learn not just to recognize pain, but to address it with dignity, compassion, and attentiveness that every person deserves. Guide our conversations and reflections, that this gathering may inspire action toward healing for those who suffer. Lord, we pray that through this lecture, we may gain the wisdom to be agents of comfort and hope in a world where so many live with unspoken pain. And may your Spirit move among us, bringing understanding, healing, and a renewed commitment to serve those in need. All this we ask and through your Son, Jesus Christ, our Lord. Amen.
Thank you so very much, Reverend Kumar. And with blessings, ladies and gentlemen, we proceed with a selection. We are blessed in many, many ways. And one way that we are blessed is that we have the beautiful Christine MacDonald Nevers as a member of our church, and in fact, the head of our choir. And so Father Pat has generously asked her to come and perform for us, and it is us that receive the blessings. Ladies and gentlemen, she's going to help us smile on this beautiful afternoon as she sings her rendition of a song by Nat King Cole. Put your hands together and welcome the remarkable Christine MacDonald Nevers.
Smile, though your heart is aching. Smile, even though it's breaking. When there are clouds in the sky, you'll get by if you smile through your fear and sorrow. Smile, and maybe tomorrow you'll see the sun come shining through for you. Light up your face with gladness. Hide every trace of sadness. Although a tear may be ever so near, that's the time you must keep on trying. Smile, what's the use of crying? You'll find that life is still worthwhile if you'll just light up your face with gladness. Hide every trace of sadness. Although a tear may be ever so near, that's the time you must keep on trying. Smile, what's the use of crying? You'll find that life is still worthwhile if you just smile.
Very well done. Mrs. Christine McDonald Nevers, give her another round of applause, please. We don't have enough money to pay her. As I heard Christine sing, what went through my mind is, can you imagine if you were alone at home in pain? What could comfort you would be her voice, and it would just ease the pain. Regrettably, we can't all have her at her house, so thank goodness that we have other solutions coming up in just a short moment. With regards to the lecture series, I have been privileged to be a part of this series for a few years. I remember when Father Pat first called me, it was Dr. Herbert Lawrence who gave a presentation next door in the church hall, and I was amazed. Dr. Lawrence dropped so many facts and figures that were intuitive, but when he put it together, you understood what he was saying about fatherhood in Jamaica, and that resonated with me. Even with the pandemic, we did not stop. We had Dr. Celia Christie Samuels as one of our presenters. We've had Professor Rosalie Hamilton, who is currently advocating for reparations. We had Adrian Dunkley to speak about AI and the threat of AI. And we've had a number of very distinguished lecturers over the course of this series. And the purpose of the series, the reason why St. Luke's continue to do this, and I hope that you understand and benefit, and you being here is a testimony to that. The St. Luke's annual lecture series hosts functions that explore health and faith and spirituality and money issues and things that we need to know as Christians moving forward in that Christian mindset. Yes, we are in the world, some of us not of the world, but we still need to navigate through it. And the beautiful thing about St. Luke's Church is that we are working to provide practical resources as Christians that we can live our lives. And I thank you for joining us for the lecture series. When you go to church on Sunday and you see the rest of the congregants, say, how come you weren't here? And you should have been here. And I certainly hope to see you next year when we continue this very important lecture series. With that said, I am sure you are ready to hear from our keynote speaker. But before she comes up, I will ask Mrs. Patricia Donald Phillips to give her the proper introduction. Please make her welcome. You prefer this or you prefer
Good evening, everybody, and to all those out there in the virtual world. Jamaican people say them take kin teeth and cover heart bun. So we are so grateful for that smile, because enough of we have some pain underneath the kin teeth. It is my distinct honor and privilege to be able to introduce to us this evening someone who has a solution for us. Jamaican people love to complain, and church people love to complain, but hey, this evening we have solutions. You know, right now we are witnessing the devastating effects of war, from the conflict between Russia and Ukraine, the ongoing violence with Palestine and Israel, the unrest in the Congo. Right here in Jamaica is 5 people them dropped the other day, if you're following the news. So pain ramifies our society. It's not just the physical, it's the emotional and spiritual. So we are really thrilled within the Diocese of Jamaica and the Cayman Islands that we are so relevant. You ever hear people say that church, not now go on with church? We are relevant. Our church is relevant. And so we're so grateful that we have a daughter of our church. I had the privilege of being taught by her dad when I was at the theological college. And we are just awed that you're carrying on this legacy of education, Dr. Stacy. Dr. Stacy Davis is a board-certified adult rheumatologist. I'm going to show her my finger, them as well. So I'll be listening keenly. She earned her medical degree from the University of the West Indies, Mona, and later completed her internal medicine residency at the Carillon Clinic, University of Virginia, and rheumatology fellowship at the Medial College of Georgia. Dr. Davis is an international fellow of the American College of Rheumatologists, current secretary of the Caribbean Association of Rheumatology, and a past president of the Lupus Foundation of Jamaica. She also currently serves on Jamaica's National Health Fund expert panel of physicians. And I said to her, how you energize yourself? She said the garden, travel, and sometimes just having her being. Well, we're so privileged that her being this evening is being a part of us. Thank you so much, Dr. Stacy.
This is fine. All right, evening everyone. I'd like to thank you for that warm welcome. I'd like to thank Archdeacon for inviting me to be here with all of you. And when Archdeacon asked me to speak on pain, and he said, choose a topic and send it to me. I thought about it for a little while, and then I decided I wanted to send something that had some sort of an impact for the topic. And so that is why I chose pain, the fifth vital sign, because I find sometimes we think pain is something we can just ride out. You know, we can just tough it out. And pain means a lot more than that when it comes to the impact it has on our bodies. Who's moving the slides? Okay. All right, so I'll have to talk this way. But how will they know when to change? Okay. All right, so we're going to talk about what pain is. We're going to look at why it is important. We're going to look at the types of pain. And then the second half of the presentation will focus on musculoskeletal pain, because as you heard, I'm a rheumatologist. For those of you who know, we deal with illnesses of the musculoskeletal system like arthritis, and we deal with autoimmune diseases. But it's not just because I'm a rheumatologist why we're going to focus on that, but because it's an important health issue that affects many persons. I was also very pleased when I heard that October is celebrated as Health Month by you, because October is a very important month in the rheumatology calendar. For example, in Jamaica, we still celebrate October as Lupus Awareness Month. And lupus is a very devastating illness that affects many persons in our population, especially females. And the other thing that's important is that World Arthritis Day is actually October 12th. And I think very often we have so much else going on in October, Breast Cancer Awareness Month, Mental Health Day, that World Arthritis Day kind of gets, forgotten. So it's good to be speaking to you today in October. And the last thing we look at, which I think is the part that you may find most useful, or I hope you'll get something out of it, is how to manage your pain. All right, so we're going to go ahead. So the first thing we want to do is define pain. And pain is really an unpleasant bodily sensation that causes mild to severe physical discomfort and emotional distress. And it typically signifies that there is some sort of tissue injury going on in the body or some form of disease. The thing about pain is that it's actually quite complex. It's complex because it's a very subjective symptom. So it's not something necessarily that the doctor can look at and quantify. And it depends a lot on the person. People have different pain thresholds. And so the impact of one stimulus on one person may be different than another. And then there are multiple factors that we're going to touch on that also influence pain and make it somewhat of a challenging condition to have, but nothing that we can't deal with. So the first thing I look at is the two main ways of looking at pain. You can break it up into acute pain, which is short-lived pain. It's sudden and usually due to injury or inflammation in the body. And really what that is a warning sign. So if I were to give you an example, you're cooking and you accidentally touch the hot pot, you feel it, and you withdraw your hand quickly. So the sensation of the pain was a warning that something dangerous or harmful is happening, and you're able to respond and remove your hand. And that spares you from having further injury to that area. And then the second broad category of pain is chronic pain. And this refers to pain that lasts for greater than 3 months in the body. And it can really actually not just be a warning sign, but it has stayed long enough that it has become its own disease state in your body. So it's a whole different animal than just short-lived pain, right? And it usually represents that there are severe problems going on in the body, some sort of compromise to your health while you have this long-term pain occurring. So if we go back to the topic of the presentation, pain, the fifth vital sign, the first thing is for us to define what a vital sign is. I think most of us have an idea. Your vital signs are those things that indicate the status of very important organ functions in the body. So, we think of our blood pressure, our heart rate, our respiratory rate, right? And it gives us a clue if a vital sign is deranged, that there's some possible ill health going on. The concept of pain, the fifth vital sign, came into being almost 30 years ago. And the American Pain Society coined that term to try and bring awareness to the importance of pain. And they also wanted to try and reduce this pattern of behavior where there was underassessment of pain and inadequate treatment of patients who had pain, right? Because we recognize that when we treat pain, it helps the overall health of the patient. Another interesting thing that ties pain and vital signs together is that if a patient has severe enough pain, it actually will affect their vital signs. So if we look at this table, if you look at the first bullet, if a patient has significant pain, it causes an increase in their heart rate. It can also increase blood pressure. And if you look at the last bullet, it can also increase respiratory rate. So we see that it is tied into the vital signs of the body. And in addition to that, pain can also cause other physical derangements or responses in the body. So number 2, we see diaphoresis, which is just a medical term for excess sweating, right? It can actually increase your blood sugar levels because pain causes a stress response in the body, and that causes the blood sugar to go up and cause dilatation of pupils and other stress response and cause increased muscle tension. And then that becomes a loop because when the muscles are tense and taut, that too can elicit further pain. So if we go back to the ever-enduring definition of what health should be, this was provided to us by the World Health Organization in the 1940s. And the important thing to note is that this definition of what we should aim for health does not just reference the absence of disease. It talks about a holistic approach to health, and one in which there's complete physical, mental, and social well-being. So if we look at chronic pain again in the context of the definition of health, or what we aspire to as having as our health, we also, apart from the physical things we've discussed, note that it impacts the social well-being of the patient. So you go to St. Luke's Church and you sing in the choir, and you have to get up and sing and sit down and get up and sit down, and you're having so much knee and back pain. After a while, it is difficult. Everybody wondering why you can't keep up, and then you just decide, boy, it's better I don't go to church because I feel so embarrassed, so I just stay home and listen to church online, right? You go into the work field trip, and you go into Dunn's River, or you go into a Blue Mountain hike, and you can't keep up. You're the one keeping back the group, right? So you don't bother to go to the field trips. You come up with a nice little excuse why you can't come, and you just stay home. And this is how your health leads to social isolation. And then in the workspace, we have the problem of, because you're struggling at work, whatever, you may have a manual job, one that's physical, you can't get ahead. You can't finish your tasks, so you're not making as much money if you're a tradesman. Your boss notices in the office that you're not keeping up, right? You're costing them too much because you get a doctor's note saying you need a new chair and your workstation needs to be ergonomically fitted, and then you become a problem, right? And so you don't advance, and then your financial mobility is affected also because you're having pain and you're having a health issue. And then if we look at the mental component, human beings thrive off of a sense of purpose. So that whole sense of not being able to self-actualize because you're having a health issue affects that sense of purpose. And in affecting that sense of purpose and having to dummy down some of your ambitions and some of your dreams, it then leads to depression and anxiety. So we see that pain encompasses every aspect of that health spectrum that we are trying to achieve wholesomeness in. So let us further define health. The first thing we looked at was we based it off of the duration. Is it short-lived pain rather, or is it long-term pain? But there are other ways of defining or classifying it. And the reason you want to classify your pain is because it helps us to then determine what's wrong with you and then hopefully come up with a better solution in how to improve your quality of life, right? So we may also define pain based off of the location of the body that is affected. And so certainly, if your head is hurting you, you're having a headache, you would hope that the doctor's approach would be different than if you came in and told them your knee was hurting you. So location matters, right? But location is not even simple, right? Because what we know is that pain can be felt by a patient in one part of the body when the pain is actually originating in another part of the body. And that is called referred pain. So if we look at this diagram of this lovely gentleman, we see that his shoulder, one shoulder, is colored in this aqua green looking color. And then if we look to the right, there's a key, a code, color code for the key. And the shoulder pain that this gentleman is having is actually arising from his liver and his gallbladder, right, which is in his abdomen. And that is very common. People who have gallbladder problems often show to the doctor and complain about shoulder pain. So, sometimes you go to the doctor and you feel so unfulfilled. You had a big shoulder pain, you went to the doctor sent you for an x-ray, you eagerly go back for your follow-up, and then the doctor looks at you and says, but the shoulder x-ray is normal. And you say, imagine I spend all this time sitting down in the waiting area, I spend my money and I don't get an answer. But these are the reasons why, because the body is complex and things are not simple. And sometimes it takes layers of investigation before we can actually get to the cause, the root cause of why somebody is having a challenge. If you look towards the other shoulder on the other side, we see a kind of burgundy color. And if we look at the color code, we see that burgundy represents the heart. So yes, the shoulder and the left chest have burgundy. And we're not surprised that the heart would be associated with the left side of the chest. But what is interesting is if you follow the burgundy coloration, you realize it goes all the way down the arm, right? And a little tips up to the neck. And I'm sure some of you have heard that when persons are having a heart attack, they tend to have the pain radiate down the arm. So that illustration is also to point out that yes, sometimes we feel that pain close to where the problem is, but sometimes it also moves elsewhere. So pain may be felt where the problem is, it may be felt in an isolated area, and sometimes it moves and goes to other areas. So then if we look at pain based off of intensity, and intensity matters because somebody who is having mild pain, it will not affect their functioning as much as somebody who is having severe pain, right? So we usually break it up into mild, moderate, and severe. And so how severe pain is largely determined by what the patient experiences. And that could vary. Some patients will tell you that they're dying, they're deading, and they're sitting quite comfortably in the chair, right? And there's no change in their vital signs, and they walked quite, normally into the examination room. And then you'll have another patient who says, well, doc, yes, the pain isn't so, it's bothersome. They're not complaining a lot, but when you look at their vital signs and you compare it to the normal pattern of what their blood pressure is, you realize that there's something impactful happening to them. So one of the ways we try to get around that subjectivity, it doesn't fully eliminate it, is that we come up with pain scales that try to somewhat standardize how we assess how bad is the pain, how much should we respond, how aggressive does the treatment need to be. Because of course, if your pain is mild, you may be able to use milder pain tablets, paracetamol. But if you're having excruciating pain, it may require an injection or a stronger pain tablet. And so what we have are pain scales that look at pain from going 0, you're not having any pain, to 10, which is the worst possible pain. And we ask patients to say, on a scale of 1 to 10, how bad is your pain, right? And so 1 to 3 is mild, 4 to 6 is moderate, and then going up to 8 to 10 or so, we think that this is pretty bad pain. We also use pectorals, right? Because sometimes our patients are young. Some of our patients may not have the same literacy. And sometimes we do see patients who their first language is not English. We have quite a few foreigners in Jamaica. I see people from all kinds of places I had no clue lived in Jamaica. And so sometimes pictures say 1,000 words, and it helps the doctor to understand what the patient is experiencing. So the last categorization of pain is the etiology. And the etiology just means where is the pain arising from? What is the cause of this pain? And we can split it up into 2 major groups. You have nociceptive pain, which is usually the pain that comes from tissue injury. And we can break that category down into visceral pain, and your viscera are your organs. So is this pain from the heart, the kidneys, the lungs, and then somatic pain, which are the generalized tissues, as in the skin, the joints, the muscles. And then on the other arm, we have neuropathic pain, which is just a word to describe pain originating from the nerves. And within that group, the pain can either be central, so it's coming from the brain or the spinal cord, or the pain can be peripheral, so at the extremities. So an example of peripheral pain would be the diabetic, who the diabetes starts to affect their nerves, and they develop diabetic neuropathy. Or another form of peripheral nerve pain would be carpal tunnel syndrome, where the nerve passing through the channel in the wrist gets compressed, and that entrapment causes the patient to experience pain. So we said that we're going to do a little focus on the musculoskeletal pain. So why is musculoskeletal pain important? Well, over 1/5 of the patients who go to their GP present because of some form of musculoskeletal pain. The most common causes are some form of arthritis and back pain, right? And then other fairly common reasons why patients will go complaining of musculoskeletal pain include gout, problems with the tendons of the body. So tendonitis, very often rotator cuff, the wrist tendon are very common. But tendons all over the body can start to give trouble for various reasons. Bursitis. And what bursitis refers to is that right around all your joints, you have little sacs filled with joint fluid. They act as shock absorbers. Because every time you step, there's a force being put on your joint. And so to disperse that force and reduce the damage of joints and to make smooth movements, we have bursas. They are shock absorbers. And then fibromyalgia, which is really pain coming from the nerves that don't work well and causes a lot of generalized pain to the patient and can be quite debilitating in some patients. So it's interesting to note that the number one common cause of disability is chronic musculoskeletal pain. It's the second leading cause of acute disability. And, very important to note, that 2/3 of the patients who present because of musculoskeletal pain are under the age of 65. Because we sometimes think that pain is an old age people thing, that when you get old and it just, you can't do much about it. But the truth is that we see persons with arthritis as young as age 2, what we call juvenile idiopathic arthritis. And then a lot of young people will have more mechanical pain. They play sports, they may get strains and sprains, But even in the world of inflammatory chronic disease pain, we're seeing it more and more in younger and younger persons. 25% of people over the age of 60 have had significant pain and some degree of disability from osteoarthritis. So osteoarthritis is that wear and tear arthritis. As you get older, you're more prone to it. You're also more prone to it with injuries. And then interestingly, 10% of all surgeries are actually orthopedic. And so this too indicates what the burden of musculoskeletal pain represents. And then of course, illness has an economic impact. It's not cheap to be ill, unfortunately, both for the individual and for the society. And so when you add up the cost of hospitalizations and office visits, monitoring tests, the treatments, and the fact that many persons cannot work when they have certain forms of musculoskeletal pain, the impact is enormous. If we look at data from our society, it's interesting, even to me, surprising to me, that arthritis is the second highest enrollment on the NHF card program, because I thought diabetes and hypertension would certainly win, right? But this is data coming to me straight from NHF, right? So let's look at the joint, right? To understand musculoskeletal pain, we look at the joint and we get an idea of all the levels at which we can have pain. So a joint, a simple joint, is where two bones come together. So we have one bone at the top, another bone at the bottom. The surface of the bones has a little gray color, and that's the cartilage. And that's that smooth, hard surface that makes us move our joints pain-free. Cartilage has no nerve endings, and when it's nice and smooth, it doesn't cause any friction or any rub. Some of us, as we get a little older, we start to hear these cracky sound, grating sounds when we move. And that's because the cartilage has broken down, right? And so you can't sneak up on anybody anymore because they can hear you coming. But normally, before that started to happen, you had those two nice smooth surfaces. Around that nice smooth surface and the two bones, you have synovial fluid. So there's a small amount of fluid that's supposed to be in the joint, once again as a cushioning, but that fluid also is nutrition to the joint. That's how you carry nutrition, because the lining of the fluid is that synovial membrane, which is actually cells which are alive and metabolizing, right? Around that, you have a fibrous joint capsule. So that's a sturdy wall keeping everything together. And then, after that joint, you still have some structures that play a role in the musculoskeletal system. So the top left, you see that there's something called a tendon. And the tendon is what attaches your muscles to your bones. And a little lower down, we see that bursa, the same thing I mentioned. Just a nice fluid-filled sac doing a protective role. But the unfortunate thing is that when the body becomes inflamed, just like how the joints become inflamed, these bursas can become inflamed and can also cause pain. So when you're localizing pain in a joint, you have to remember it may come from within the joint, which would be the joint capsule, the subchondral bone, which is the bone right underneath the cartilage, and the lining of the bone, right? Or it may come from around the joint, what we call periarticular pain, and that's when we have to consider whether the tendons are the problem or the soft tissues. Sometimes people just have knotted areas of tissue that are concentrated with nerve endings and muscles, and those can be painful, or whether it is nerve pain. Next slide. So if we look specifically at arthritis, the word arthritis literally means inflammation of the joints. But in layman's terms, we actually use it to mean anything that is a disorder of the joint, right? And usually it results firstly in pain and sometimes swelling. And if it's left there untreated, can lead to loss of range of motion and function. Now, in the Jamaica Health and Lifestyle Survey, which went on about 16 or so years ago, 1 in 20 Jamaicans said they had arthritis. I actually think that's an underestimation, right? Because we know that people are more aware of arthritis now, and so people are showing up and showing up early. A lot of patients are coming in without a referral because they realize that something can be done to help them. And so I'm sure if we were to do another survey, the numbers would be much higher. When we look at the data from the CDC in the US, in 2020, 1 in 4 adults said that they had some form of arthritis. So if there were 20 of us in here, about 5 of you or so may have some arthritis going on. Everybody? Oh dear. All right. So a simple way of looking at the more common types of arthritis is to put the normal joint there and then look at osteoarthritis as a simplified picture. So osteoarthritis is a wear and tear arthritis, right? And what we see is that that nice space between the two bones is lost. And we see that that nice covering of the bones, the cartilage, has worn away. And now it's thin, so it's not as protective as it used to be. And then when we look at rheumatoid arthritis, which is now inflammation in the joints, you may not have as much loss of the joint space, but what you have is swelling of the fluid. And if that stays there long enough with all the inflammation that's damaging, the bone also gets damaged and eaten away, what we call erosions of the bone. So if we look at osteoarthritis first, because it's the most common arthritis, we refer to it as the wear and tear arthritis. As we've known more and more about and learned and understood arthritis more, we realize that there is a local component of inflammation, and that's part of the reason why those joints hurt so much. But it's not the same extent of inflammation like autoimmunity, where the whole body is inflamed. It's a progressive process. When you have osteoarthritis, for most persons, it will progress. There are things that you can do to limit. You know, if you're doing very heavy work on the joints, manual work, athlete, reducing the load and the pressure may help. Weight loss may help. But for the most part, it is something that can progress. And the most commonly affected joints are the hands, the knees, the hips, and the spine. So osteoarthritis, you get pain. And this pain is usually worse later on in the day. You've been up and about, you've been using the joints, and they're already worn out. So by you pressure them some more, they really start to hurt. You can get stiffness with that, but it's usually not prolonged stiffness, right? So that's one of the ways we distinguish wear and tear arthritis from inflammation. Because with inflammation, the stiffness is a main feature that stays for much longer periods. Of course, there's loss of the range of motion of the joint. So when you lose your flexibility, the joint is no longer as functional as it used to be. We talked about that grating, cracking sound. We refer to it medically as crepitus. And some people, especially like in the knee or in the fingers, sometimes you see joints enlarging, right? And that's really a functional. Whenever our bodies are out of balance, our bodies try to repair themselves. And many times you don't even realize something was going wrong because the homeostatic mechanisms of your body kick in, it corrects itself, and you go along your merry way. When it comes to arthritis and wear and tear, the body tries to repair itself. And what it's trying to do is regenerate that cartilage, that protective cartilage at the end of the bone. Unfortunately, we cannot regrow that type of cartilage. And in error, what happens is that excess bone is produced. And that is what leads to the enlargement of the knee, and the fingers get knobby. And you know something is wrong because you can actually see it. For osteoarthritis, we use mainly imaging, x-rays. Sometimes we have to move on to other imaging modalities like MRIs and ultrasounds to get a good idea as to what is the cause, what is the extent of the arthritis, because we know if it's mild, we could tell the patient use a topical rub, do a little gentle exercise to strengthen the muscles around. But if we do imaging and we see that it is very severe, we know that we have to also be a little bit more aggressive in what we offer as the treatment. So mention those. Paracetamol is the first line in terms of medication. Many people will tell you it doesn't work, but we feel that it is the safest tablet to take on a long-term basis. If that doesn't work, we move on to NSAIDs, which are your non-steroidals, your cataflam, your Voltaren, your ibuprofen. The concern with those, though, is that there's a higher side effect potential. NSAIDs are great, but we have to worry about the impact on the stomach. We have to worry about the impact on your blood pressure, your cardiovascular system. So even though these things are sold over the counter, it can bump up blood pressure. It can add to cardiovascular risk. And even kidneys, they can have an impact. So you use them judiciously. As with everything, it's about using it the right way, and then you limit side effects and you get the benefit. When the pain is not responding to that, we go to stronger drugs like narcotics, like tramadol. And then a very important modality for patients is physiotherapy. If you want to reduce the amount of medication you're taking, physiotherapy and occupational therapy are very useful, right? Last resort, for osteoarthritic patient is that the medical doctor, such as I, says, I can do no more, and I send you to the orthopedic colleague who now does interventions for the patient. It's interesting to look at which joints are affected, because one of the ways we tell what type of arthritis a patient has is what location of the body is affected. So for osteoarthritis, common joints are the knee, the hip, the hands, the feet, the neck, and the lower back. Rarely does primary osteoarthritis, and I focus on primary, because you can get secondary osteoarthritis from injuries or from having inflammation long term, but rarely does primary osteoarthritis go for these knuckles here, called them MCPs, go for the elbow or the ankle or even the wrist. Next. So lets us move on to the next big category of arthritis, inflammatory arthritis. And there are over 100 types of it, right? So very often patients say, I have arthritis, and they think that's it. But arthritis is just a group of illnesses, of which there are many. So with the inflammatory arthritis, you tend to get a lot more swelling of the joints. We mentioned before, the stiffness tends to be prolonged. So it's at its worst when you're getting out of bed in the morning, and so is the pain. So the pain of inflammatory disease is worse in the mornings because you've been stationary for so long. The joints kind of seize up on you. And then as you get going, they kind of loosen up a little bit, and the pain is a little bit less. Whereas the wear and tear arthritis is you're on the joint so much, the joint already worn out, so now you're just pressuring the worn out joint. You can get more warmth with the inflammatory type arthritis, and tenderness along the joints is more prominent. In some cases, you get redness to the joints, such as in acute gout, or if you have infection in the joint. And then, very often, if not treated, you will get significant deformity from inflammation in your joints. So the most common form of an inflammatory arthritis is rheumatoid arthritis. It's a chronic, so it's a lifelong illness that we cannot cure. It's systemic. It can affect from your head to your toe, so it may start in your joints, but it literally, because it's a manifestation of your immune system not working well and actually attacking your own tissues, it can spread beyond the joints and affect other parts of your body. And so the treatment of inflammatory arthritis is not just relieving pain, but it is controlling the immune dysfunction, which is associated with a lot of other health complications. And so it's characterized by inflammation leading to cartilage and bone damage, joint deformity, and worst of all, disability. And the thing about inflammatory arthritis is that they occur in young persons, right? And so it affects people in the most productive stages of their life. Another thing is in 30 to 40% of patients, it goes outside the joints. So the eyes are a common area that are affected, the lungs are commonly affected, and the nerves to some extent. For you to have rheumatoid arthritis, you would have your pain for over 6 weeks. We mentioned worse in the morning and with inactivity. And then on examination, the doctor will see swelling that's palpable. They can feel the sponginess, the tenderness. And we mentioned all the other features already. Usually rheumatoid is symmetrical. So usually wear and tear arthritis, you may have maybe just one bad knee. Sometimes you have two. But with rheumatoid, you tend to have whatever is happening on one side of the body occurring on the other. It's predominantly a small joint disease, so that means the knuckles, the fingers, the toes, and then also it may affect medium-sized joints like the knees and the shoulders. It may affect your jaw. So arthritis commonly affects your temporomandibular joints, can affect eating, talking, and then the acromioclavicular joint, the AC joint, that is up here in the shoulder, and the sternoclavicular joint. So this can be a widespread effect of having inflammation in your joints. In terms of the spine, rheumatoid only affects the neck, the upper spine. If you have pain lower than that, you should look into if there is another cause. The other thing that should make you wonder if you have something more than wear and tear arthritis is that when you have an inflammatory arthritis, you tend to get symptoms that are very generalized. You get fatigue, you may have these low-grade fevers even though you're not ill. You can have loss of appetite and weight loss. And you get this kind of a recurrent sore throat. So you feel like you're getting a little flu, but it goes away, and then the sore throat comes back. And that's just because your immune system is overactive, and your tonsils are part of your immune system. So for rheumatoid, as you said, small and medium-sized joints predominantly. So fingers, toes, wrists, spares the outer joints of the fingers. So the ones just before your fingernail, rheumatoid doesn't like those joints, right? And how do we evaluate? So if we suspect you have this condition, we're going to do measures of inflammation because this is an inflammatory autoimmune process. We do markers specific for the illness, and then we check x-rays to look for features that would hopefully confirm that this is rheumatoid. Treatment. So whereas with osteo, we're looking at pain management, strengthening the structures, some behavioral changes. With rheumatoid, yes, we certainly need to relieve your pain. We focus mainly on anti-inflammatory pain drugs, but you also need to treat the underlying cause, which is the immune derangement, and we use medications that are called disease-modifying drugs, right? And what we're trying to do is modify or change the course of this illness, because if you don't treat this, it is going to lead to progression and affecting organs, increase your chance of certain cancers, increase your chance of premature cardiovascular disease, and stroke. And I'm not talking about premature as in 40. I have patients that are 18 years old who have heart attacks and strokes from autoimmune disease. So monitoring is very important once you start treatment in order to adjust therapy to optimize care. And also, apart from monitoring the joints, you want to monitor for the complications of the illness. Another thing is that the autoimmune patient is an immunocompromised patient, and some of the medications we use, unfortunately, suppress the immune system. So another important measure of how well they're doing is assessing their risk or trying to prevent infections. So these are patients who may need to get the annual flu shot and just take extra precautions in terms of not getting sick. Gout is actually a metabolic derangement where you have too much uric acid in the body, and it can accumulate in your joints, create an intense inflammatory reaction leading to an arthritis. So this is more of an episodic arthritis where you get intermittent gout flares. Usually occurs in the big toe, but can really occur in almost any joint, and it's related to that because uric acid is actually a byproduct of certain types of proteins that we eat. And so the first mode of treatment for gout is actually diet change, to try and eliminate the foods that can build up your uric acid level in the body. Interestingly, just like autoimmune arthritic processes, gout is not limited to the joints. So gout, the same crystals can cause kidney stones, right? So it can affect your urinary tract. Also, that inflammatory state also increases your risk of hypertension, of cardiovascular disease, of chronic disease. So this is where we try to point out again that pain syndromes are not simply just pain. They literally affect all aspects of your body. We use drugs that are anti-inflammatory. If the diet alone is not sufficient, we can use other drugs to lower the uric acid level for you, especially if you have severely high levels. And usually those interventions are sufficient for managing gout. I put lupus here because it is probably one of the more commonly known autoimmune illnesses now, which has an inflammatory arthritis component, right? And if you look at this bar graph, you can see, well, you really can't see, but at the bottom, the incidence or the frequency of the symptoms is there. So as you go from left to right, the more often the patient has this symptom if they have lupus. And so painful joints and swollen joints occur in 90% of cases of lupus. So even though it's an illness that affects lots of parts of the body, we commonly associate it with rash, we associate it with kidney problems, with hair loss. Joints are a big component of the condition. So I've given you a lot. You may say, wow, over 100 arthritic processes. What are the things that the doctor is going to use now to kind of narrow down what's wrong with you? Why do you have your pain? Demographics are very important, right? So we always say the history is the most important part of the intervention of a doctor and a patient with the physical exam, and then the investigations are more to confirm the suspicion. And so demographics play a big role when it comes to autoimmunity and arthritis, because we know females are more likely to have certain conditions, such as lupus and rheumatoid, and then males are more likely to have other things, such as gout. And women, in fact, don't tend to experience gout until they're postmenopausal, because estrogen is actually protective against the illness. And then race plays a role. There are certain conditions that you see more in people of color, such as lupus, and that's why it's so common in our population. And then there are other things that we don't see so commonly that you may see in other races. The age of the patient is also important. So we know lupus occurs in the fertile female, and most cases occur in the 20s. That's when patients start to have symptoms. But then there are other conditions such as osteoarthritis, which is more common as you get a little older, at 50 and above. So apart from arthritis, what are the other things that cause joint pain? We talked about a couple of those at the top, so I'm just going to highlight a few. So hypervitaminosis is just a way of saying low vitamin D levels. And low vitamin D levels, surprisingly, are quite common even though we live in the tropics. But because we have such indoor lives nowadays, and we're told to wear sunscreen, sometimes we don't produce the vitamin D we need to. And just being deficient in vitamin D by itself can cause joint pains and is a risk factor to developing autoimmunity. Hepatitis and a number of other viruses also lead to arthritis and joint pain. Hypothyroidism, so patients who have thyroid problems can land up having joint pain. I'll go right down to the bottom and note depression can result in joint pain. So sometimes when emotionally we are not in a good place, it can actually cause physical manifestations in the body. And to note, not to vary away from taking your medications, but there are drugs that can contribute to joint pains. So statins that we use to treat high cholesterol in some patients will result in joint and muscle pains. And some bone strengthening drugs, I don't remember the days when Sally Field used to advertise, I think it was Bonivo. Those two in some patients can result in pain. So how do we diagnose? History, physical exam, investigations, and more investigations. If we think that you have nerve pain, we rely on things such as nerve conduction tests, where we send you to a special kind of doctor who is going to stick some needles inside of you and see how those nerves are firing. So treatment, we have pharmaceutical modes of treatment, and we've spoken about most of these already, so I'm going to skip over this. But bear in mind that the type of pain is what determines the type of treatment, right? So severity, the type of pain. So for example, for nerve pain, we have drugs such as gabapentin and Lyrica and amitriptyline, which target nerve pain directly. You would not use that in a patient, though, who is having rheumatoid arthritis, because it would not be as effective. And then you have viscous supplementation, and that is when synthetic joint fluid is manufactured, and that can be injected in certain joints, such as the knee, to kind of put back that cushioning that has been lost with osteodegenerative arthritis. You may go to pain management doctors who give epidural shots, which can have lidocaine, which is an anesthetic, or steroids in there. And this is particularly helpful for patients who have spinal pain, right? And then in recent times, orthopedic physicians have had a number of other injections that they can offer patients, right? So some of this not so invasive surgical interventions that they can offer is platelet-rich plasma. They get some of your blood, they spin it down, they extract the platelets, and platelets actually have growth factor, and that is what helps to get the joint back in a good place. There's some person using stem cell injections, and then there's arthroscopic surgery, which is also thought to be minimally invasive, where they make 3 little holes, and they manipulate through those holes. So it's supposed to reduce the healing, right? And be able to address repairs of things such as tendons, or if you have osteoarthritis, it can clean up all of that frayed cartilage, which is adding to some of the discomfort. And then, in some instances, people may have trigger fingers, and they simply need to have that tendon released. And you go all along the spectrum until you reach the point of needing to replace joints, which would be a significant surgery. So I think this is a part now where Jamaicans culturally prefer to steer their therapy. And that is moving away from drugs, and what are the other things that can be done. So we've mentioned physiotherapy already. We mentioned the benefits of exercise. And exercise, apart from strengthening the supporting structures around the joints, exercise itself reduces inflammation in the body, right? And has been clearly shown if you have sustained exercise, not sporadic, once a month, but it actually helps significantly with inflammatory pain. It also helps to elevate your mood. So you're somebody struggling with pain, your mood is affected, it can help. Those endorphins can help you to feel better generally. Things like the use of splints, braces, ice, heat. I don't know if any of you are familiar with TENS units, that's little electrical impulses that can also help to limit pain. And then diet. This is a question that we get a lot, right? What can I do to change my diet to help with my pain? Rheumatology is a little behind other specialties in terms of having standardized diets. Gout was the only one we had for many, many years. And about 2 years ago, they published guidelines for rheumatoid arthritis. And basically what it said was a Mediterranean diet, which I'm not sure if that's compatible with our food choices, right? But in essence, what that is saying is eat as naturally as you can. So you're going to eat white meat, fish predominantly, a little chicken, and you're going to avoid inflammatory meats such as red meat and pork. You're going to eat natural foods. So less out of what comes out of the supermarket and more what comes out of the market or out of the ground. So you're going to eat your ground provisions, right? You're going to eat your breadfruit, you can eat your bami, but not a whole lot of rice, not a whole lot of biscuits and crackers and anything processed, things out of the tin, not the processed meats, right? And then, of course, as much fruits and vegetables as you can eat. You have to be a little cautious with the fruits because some of those delicious fruits are loaded with sugar, and sugar is inflammatory, right? But eat as naturally as you can. And we know that there are certain foods that have anti-inflammatory properties. Turmeric is getting a lot of attention now, even within the medical literature. So I know that has been out there. You know, there are many things that country people discovered long before, right? But they're actually paying attention to those things. So, you know, the use of things like turmeric, to some extent ginger, cayenne pepper. The one supplement that has been identified and has been protocolized for us in rheumatology is omega-3 supplementation, right? But for it to be useful for joints and for your immune system, you actually have to use high doses. So the recommended dose is 2,000 milligrams of omega-3. And I want you to listen carefully. 2,000 omega-3, not 2,000 fish oil. Because you can have a fish oil capsule that says it's 1,000 fish oil, but it only has 300 omega-3. And so for you to get to 2,000, you'd have to be taking 7 of those a day, which nobody wants to do. But you can find those that have high doses of omega-3, and you only have to take, 2 a day. And you can also supplement some of it. If you know that you're eating regularly foods that are high in omega-3, you can add up the foods. So those are your sardines, your tuna, your salmon, flaxseed, things like that have a lot of omega-3 in them. Some people need some help to cope with the illness. And there are different psychotherapy modalities that can help with pain management and help to lessen pain, both physically and emotionally. The importance of rest cannot be understated. I don't think people realize how rejuvenating sleep is for the body and how it repairs the processes of our body. And stress management, which is easier said than done, but you should at least attempt. Sometimes you just have to say no, sometimes you just have to take a step back because it is important for your health. And that's it. So, I don't know if you have any questions.
Thank you so very much. Would you like to take a little rest before the questions? Yes, I think after that exhaustive and complete presentation, we deserve to let our presenter take a rest. But I guarantee you it's just a short rest because I can report that we have had as many people online tonight as we have had on church on Sunday, right? So that's very good. So will the in-person audience please clap the online audience? Who have also posted their questions, yes? So while you get rest and while it is that you compile your questions, because I have questions, so I can imagine that you do too. And as we see, it affects people of all ages, so we all have questions. Before we get into the Q&A, we thought we would have a breather, and we will welcome Miss Anne-Marie Yuan to give us a selection. Make her welcome. Would you like us to drum with you? Would you like us to drum with you?
It's not that kind of thing.
Okay, all yours.
Good evening, everyone. Unfortunately, it's not a song that you would be familiar with, but I hope it can be appreciated nevertheless. If I lose my way, if the darkness dims the light, if I forget thy greatness and thy strength, if I stumble, if I falter,
If I grow weary or despaired, if I lose my way, send thy grace. Long lost in sin, wretched and poor, and just a thief who stole from thy grace. But only the light that shined from thy heart could redeem my soul. But I'm afraid, and so afraid, and so much in need, that if I lose my way, send thy grace. Heaven declares the glory of the Lord. I stand and saw glimpses of the light, drawn to the light that canceled my sin. I was at ease and my heart at peace. But I'm frail and so afraid and so much in need, that if I lose my way, yes, if I lose my way, if I lose my way, Lord, send thy grace. Thank you.
Thank you so very much. If I lose my way. Excellent. So, Dr. Davies, I have a suggestion, if I may. Your presentation was excellent, very full. I would suggest one minor edit. Right there where you say non-pharmaceutical ways to relieve pain, and let me know if you agree. You said rest, stress management, and I think you should add singing, because boy, a wonderful song like that, delivered well, can definitely ease pain, yes? You agree, all right. So, ladies and gentlemen, we're ready for the question and answer segment. And already we have a question. This is great. So I didn't expect a question to come from the audience so quickly. So I'm going to come to you next. And I'm just going to give one. This is for you. Thank you. One of the questions that we got from the online audience was, will exercise make my chronic pain worse? They didn't indicate what kind of pain. And one of the things I learned today is that you have all different types of pain, right? But will exercise make my chronic pain worse? So I'll ask you to answer that question first, and then I'll go in.
So exercise done properly should relieve pain, right? So the first thing you have to understand is if you have compromised joints, you need to do low impact exercises. The pool is probably the best bet, right? You have the buoyancy of the water to take the load off of the joints, but of course not everybody has easy access to a pool. So your land exercises that are low impact would be walking, cycling, and just stretching exercises, things that help with strengthening. You also have to realize if you're just starting to exercise, you have to do so slowly. So what we call graded exercise, you gradually build up the exercises. It's important to also incorporate some aerobic with strengthening. Strengthening and stretching are extremely important. So sometimes you can figure it out on your own. Sometimes you may need to go to a teaching session with a physiotherapist, right? And what they would do is evaluate your individual case and then help to model or create an exercise program around. And then there are little things that you have to consider. You know, a lot about your health is a journey and learning along the way, right? So if you do certain things that you're told are good or acceptable and you don't feel like it's agreeing with you, then don't do that. Try and modify, right, what you're doing. And just little things. For example, the patient who has osteoarthritis in their knee, walking up a hill is a better exercise routine, right, in terms of building cardiovascular strength. But inclines are terrible for persons who have osteo of the knee. So that type of person should be walking on flat ground, good sneakers, and preferably grass, not paved ground, right? So putting everything together, selecting, making sure you have on the right shoes, etc. If it's done right, exercise should actually help to relieve your pain.
Excellent. Thank you so very much. I would use this opportunity to say that St. Luke's has an exercise program on Saturday mornings, and when the exercise program restarts, I'll invite all of you and myself to participate. Right? All right. Yes, sir. Thank you.
Good evening. Wonderful presentation.
Thank you.
Scholarly researched. And you've actually touched on some of the questions that I would like to ask you. They were answered in the lecture. However, I still want to ask. 6 months after a minor surgery, let's say in the groin, you know, hernia repairs, if you still have moderate pain, would it be further surgery to correct it or prescription drugs?
I certainly don't think if it's just hernia repair, you would need further surgery, right? And really, to address that, you would want to investigate what's happening. So is this just that you have very bad scar tissue and you just need analgesia, or has something else happened? So the first thing is, go back to the surgeon, make them do a thorough evaluation. If they don't find anything, then it's going to be pain medication. But the first thing is to assess that there wasn't some unwanted complication in the surgery that may need revision. But certainly surgery would be the last option to go back in.
And finally, could you, Lyrica, Lyrica, could you expound on that again, please? What is Lyrica?
So Lyrica is a drug that blocks one of the chemicals that transmit pain. So we have what we call neurotransmitter chemicals that send signals from nerves to nerves, right? And Lyrica blocks one of those chemicals, and that's why it is so useful for nerve pain. So you would use Lyrica in cases of diabetic neuropathy. You could use it for radicular pain, so that is like when you have pinched nerves. You'd use it for fibromyalgia, in which you have generalized pain due to dysfunction of nerves, right? Now these medications such as Lyrica work at the level of your central nervous system because you're working at the processing. You're trying to change the nerve processing that is sending pain signals. And because of that, you tend to get side effects like drowsiness and loopiness. So it's a type of drug that you have to build up gradually in the system and start at a low dose and build up over time in order to tolerate it. But it is one of the approved drugs to deal with a number of types of nerve-related pain.
Dr. Davis, I'm going to ask you to stand right here. Since neither of us is using this mic stand, let me move it out of the way, and then you can come back. Yes?
right.
And while you're on the topic of that drug, another question that we got online was, what are the best OTC drugs for pain, and can I get addicted? And based on your last answer, I think those are two relevant questions. What are the best over-the-counter drugs for pain, and can I get addicted?
All right. So
Sorry. We are not hearing here. I was told they were not hearing. They're not hearing the question.
You didn't hear my question? Oh, my question from online audience, and let me just give a quick shout out to who's online. We have Alicia, we have Christine Forrester, we have Audrey Forrester, we have Suzanne Francis Brown, all involved in asking questions. The question was, what are the best OTC drugs, over-the-counter drugs for pain? Tylenol was mentioned. And can I get addicted to drugs for pain?
Okay, so best in my mind means most effective as well as safest, right? So I think I alluded to it earlier that in terms of safest, paracetamol would be the first choice, right? But it's not the strongest of drugs. And therefore, many persons have to escalate to anti-inflammatories. And the two common ones we have over the counter are ibuprofen, which you also call Brufen. Sometimes it's labeled as Advil or Motrin, right? And another common one over the counter would be Aleve, naproxen. Now, these drugs are in the same class of drug, anti-inflammatories, but there are slight differences between them. So for example, naproxen is thought to be safer for your heart because I had mentioned that there is some influence on heart disease with some of these pain meds, but it is also quite harsh on the stomach. So if you know that you're a patient who already had an ulcer or you have reflux, then you're not going to choose naproxen as your best option over the counter. You'd want to stick with Tylenol or ibuprofen, right? If you're a heart patient though, and you're struggling to get something before you can get to your doctor, naproxen might be a good choice for you. Ibuprofen is a good drug, right? It's good for your pocket, so that's it, because sometimes best is also what people can afford. It's just a reality, right? So it is affordable, and for mild to moderate pain, it will work. And so the thing about saying best is that everybody is an individual case, and so there are different parameters you'd have to look at. But in terms of availability, those would be the two. If your pain is mild, what's even better is for you not to take a tablet, but to use a topical preparation. So we have things like Voltaren gel over the counter. You also have drugs that combine what's in Voltaren gel with muscle relaxants and paracetamol. So there is a rub called Flexin Plus rub, which has 3 pain meds in one. And then you have things such as Capsitop, which uses capsaicin, those peppers, and it creates a rub that is also quite effective. So if your pain is mild, your better choice would likely be to start with a topical because you limit side effect potential. And then if that is not sufficient, you go up.
And the question of addiction?
No. So the over-the-counter pain meds are not addictive.
Excellent. We have a question here. Mrs. Philpotts Brown.
Outside of injecting with gel in, say, for instance, the joints, are there any ways in which you can regenerate the gel that is in your knee, the natural one that is in your knees? Is there outside of injections?
Outside of injections?
Of these gels?
Well, I mean, the premise of the whole stem cell is to try and do some joint regeneration. It's a little controversial. It's not mainstream for everybody. Some patients will tell you it helps, some it doesn't. But as we said, we can't regrow cartilage, so the most you can do is to try and assist with the cushioning of the joint.
Can't regrow.
Not the cartilage.
Not cartilage, okay.
Thank you. Could you please explain scar tissue?
Scar tissue.
Could you please explain scar tissue for me? It's almost 3 years since I did one of my knee surgeries, but I still have this numbness on one side. It's not painful, it's just numb and feels stiff and funny.
I would presume that that numbness means that the very tiny nerve endings were clipped in surgery. Because remember, your nerve endings go right out to your skin, right? So numbness is a feature of something happening to the nerves in that location. And that's not uncommon in surgery. That's actually what we would call an acceptable side effect. If it's the tiny end nerve endings, it's certainly uncomfortable to you, the patient, right, to have an abnormal sensation there. But if we go back to your question about scar tissue, so whenever we manipulate tissue in the body, very often it never goes back to its exact state, right? And so the simplest form of scar tissue is that you are doing something and you got a cut, and you realize that when that area heals from that cut, it doesn't look identical to the tissue around it. So when you have a surgical procedure, it's basically the same thing happening, where instead of regular cells and regular tissue growth, what you have is fibrous tissue, a harder form of tissue forming to form a seal to that area that was compromised, right? So it's a natural process of the body, because in most things that we do as humans, we cannot mimic the natural course of nature. And really what you have to do is figure out whether this is harmful to you, and it's not harmful. It might not be the nicest looking thing or the nicest feel, but it's not going to do anything bad to you.
Thank you.
Any further questions from the audience? Yes? Okay, I'm coming around there. Oh, Father Pat is closer. Thank you so much. Oh, ladies first, Father. Oh, she's deferring.
Okay.
Go right ahead, please.
Okay, so recently my grandmother was diagnosed with Parkinson's, and my questions are, is Parkinson's disease an autoimmune disease, and can having rheumatoid arthritis lead to Parkinson's disease?
So no, having rheumatoid will not lead to Parkinson's. Parkinson's is not really an autoimmune illness. There is an inflammatory component though, right? But it is not considered, because it's a little challenging to explain. There are autoimmune and there are auto-inflammatory conditions in the body. So it's not autoimmune, but many of the derangements in the body will have inflammation as a component, which it does, but there is no direct link that having rheumatoid will lead to Parkinson's.
Good night, everyone. You go to the doctor, all part of you hurting, every joint hurting. You do the test, and they are unable to identify exactly the cause. You may hear, oh, I guess it's some autoimmune, but they cannot directly say that it is this one. Why is it so hard to identify which it is?
Well, it goes to, it's very complex, your body, right? And that's why people don't do rheumatology, because there's nothing simple in autoimmune diseases, right? Your immune system is a vast array of millions of things happening. And anywhere along that spectrum, one or more things can go wrong. Now, to diagnose an autoimmune condition, there is no specific test for any one condition. So if you wanted to diagnose diabetes, you do your blood sugar test. It's fairly simple. You say you have diabetes, right? You want to say you have high cholesterol, you check your cholesterol, it's high, it's above the threshold, you have high cholesterol. With autoimmune diseases, there's no specific test. We actually have to rely on criteria. And so each disease has a set of criteria, and the criteria includes symptoms, the physical exam, and the blood test. And there's a weighted scoring system. And then you have to add up these scores for each individual patient to determine if they meet criteria, right? And the truth is that these criteria were not even designed for clinical practice. They were designed for studies so that you could have homogeneous groups of patients in the studies, because otherwise you could never do an autoimmune disease study, right? To make matters worse, many patients with autoimmune diseases will have negative labs but still have the disease. Rheumatoid is a very good example of that. And vice versa. You can have positive autoimmune labs and not have disease, right? So it's like being a detective, right? And unfortunately too, I find that very often patients, when people cannot find out what's wrong with them, they're told, oh, you have an autoimmune disease. Even sometimes when there is not necessarily a good premise to that, right? So I know people like definites. They want to go and they want to hear, this is what is wrong with you, and this is what we can do for you, right? In the world of autoimmunity, unfortunately, there's a lot of gray. But there are certain important things to focus on. Establish whether there is immune derangement, right? And inflammation going on. Because there are basic standard things you can do for somebody who is having an inflammatory immune process, right? You can abate the process with lifestyle, diet, exercise, certain types of medicines. Steroids are not popular, but they are useful in the right context, right? Also, establish, has this caused damage already, right? Because damage will say you need to be more aggressive. So it's sort of like this. It's a fruit, right? And certain fruits have vitamin C. If I eat a guava, a cherry, or a citrus fruit, I'm still getting vitamin C, right? Focus on the things that actually will affect your body. What are the things that can be done? Because the thing about an autoimmune illness too is that it evolves over time, and this evolution can be years. So if you're sitting to wait and get a definite, this is what you have, by the time you get that, the process would have gone so far that it would have caused some irreparable damage, right? So as much as it's great to hear definites, we still live in a world where there are lots of non-definites. I don't know why I'm that complexion and you're another complexion. I don't know why I'm this short and you are tall, right? There are lots of things we cannot explain. But if we focus on the things that matter and we follow the patient along, sooner or later, we're either going to get the answer while we prevent the damage. And that is what's most important. Relieving the pain, maintaining quality of life, preventing damage.
Thank you so much, Dr. Davis. If I may ask this question on behalf of Christine Forrester. Christine Forrester asks, what's the best way to deal with neuropathic? Did I pronounce it right? All right. So thank you so much. For the benefit of Christine, I want you to look right into that camera. You see the camera right under the fan there, and answer the question for her. Thank you.
Hi, Christine. So it depends what is causing the pain. So peripheral neuropathic pain, say carpal tunnel syndrome. The first thing is, what is causing this entrapment of a nerve? So there are certain conditions which will predispose you. For example, having rheumatoid and the area locally is inflamed will cause carpal tunnel, and if you fix the rheumatoid, the carpal tunnel and the entrapment will go. If you're having neuropathic pain because you have a pinched nerve in your spine, you may need to do modalities, whether physiotherapy, to deal with that type of pain. So the first thing is to establish, is there an underlying cause for the neuropathic pain, right? If you're diabetic and you're not controlled, control diabetes so that your neuropathy does not progress. But if there are no interventions that you can do, then at that point, in the mildest pain, you could try simple things like, we know B6 and B12 vitamins sometimes help with nerve pain. If it is advanced beyond that, then you would have to rely on medications such as gabapentin, Lyrica that we mentioned before, and amitriptyline. But there's no cure as such for the neuropathic pain by itself. If there's an association that you can fix, you fix it. Otherwise, you treat symptomatically.
She says, thank you. If there are no question from the floor at the moment, Vilna Thomas asks, what causes trigger finger and what are the possible treatments?
All right, so trigger finger is a consequence of the tendon and the sheath around the tendon. So the tendon allows us to move, right? That's what gives us flexibility. And each of those strings, we refer to them as pulleys, is covered by a sheath, right? So the tendon is moving freely in the sheath. Whenever there is something that affects the tendon and the sheath, very often inflammation, and this inflammation can be systemic, right? But this inflammation can come from just excess use, friction, friction, friction. So you're always typing, you're always doing something like that, or some systemic illness that causes inflammation in the body like diabetes. Then that inflammation sits in that region of the body, and after a period, the inflammation quiets down, but the tissue there becomes scarred over. So what you have is a sheath that has a scar, and a scar in a circular area actually contracts the area. So the tendon now has to slide through a narrowed space, and when it slides through that scarred space, it gets stuck. So you notice with a trigger finger, you kind of have to flick it open. You're flicking it past the scar, and now it can open up and move again. So a trigger finger is a consequence of the tendon and the tendon sheath having been inflamed previously with a scar that is left and now causes an obstruction. To treat it, sometimes in the mildest cases, you look to see, is there rheumatoid, is there diabetes? Thyroid disease too is another common. Or if you have an occupational cause for why this would happen, you would try to limit whatever activity. Some physiotherapy can be good for it if it's mild, and you can do a little physiotherapy at home using one of the stress balls, or you have those springs, I can't remember the proper name, but those things that you squeeze, just that exercising of the area, right? If it's not responding to that, you can go to orthopedics and they can inject with steroids, which are anti-inflammatories. And if you're not getting release from that, then they do what is a tendon release kind of procedure. They slit open the sheath in the simplest of terms and release the area of obstruction and thereby release the trigger finger.
Okay, thank you so much. I got a question via WhatsApp. So because it's on WhatsApp, I presume that this congregant did not want her name mentioned because it didn't come up in the YouTube chat where everyone would see who it is. So her question is, paracetamol safest, but there is usually a limit to how many you should take per day and for how many days you should take paracetamol. Doesn't it affect liver or cause liver toxicity?
So definitely, paracetamol can be toxic to your liver, but so can many pain tablets, right? But it is the one that we are concerned about the liver. If you're elderly, you really should try to limit your paracetamol use daily to 2 grams per day. So each paracetamol tablet is usually 500 milligrams. You take 2 together, you take 2 twice a day, shouldn't be more than that. And persons who are a little younger, currently we say 3 grams a day. So we've moved away from 4 grams a day and we've reduced it to try and prevent the impact on the liver. So yes, it can affect the liver, but when you look at the full picture, it's still thought to be probably one of your safest bets.
Thank you. Any further questions from the floor? I see one more. Yes? No? Yes? Okay. I saw the hesitation there.
It mightn't come under what you're talking about, but I think I can think of a person who I've never seen in such pain, but it hasn't come up here at all. The pain from sickle cell. Is there anything that can be done about that? And I'm talking about, I have seen a youngster from 8 years old, and I know her now at 40 odd, and she is in terrible pain.
Right. So the pain of sickle cell, what we call a sickle cell crisis, because it literally is a crisis, right? They have excruciating pain. And the abnormal shape of the red blood cell causes these cells to get trapped in various parts of the body, leading to both musculoskeletal. They can have abdominal pain, they can have chest crisis. So it's something that affects any parts of their body. Unfortunately, we don't have a cure. We don't have great Medications for sickle cell pain, I mean, very often you have to escalate all the way up to narcotics, and unfortunately, narcotics come with a risk of addiction. But for many sickle cell patients, that is what is able to abate their pain. In recent years, we realized the use of folic acid and a drug called hydroxyurea has helped a lot of sickle cell patients to moderate their illness so that they don't have as severe disease. So that's probably the intervention we've had most recently, hydroxyurea, but it still is a disease that is very disabling to many patients who suffer from it.
Thank you so very much. Please give her a round of applause. She has been fantastic. Thank you. I have a job for you, however. I'm going to ask you to sit right there in your seat. Father Pat, I'm going to ask you to sit right there beside, yes, I want you to sit right here. Nola, if you could move up right here, please. So our online audience has been fantastic, but they've only seen our presenter. So later on, of course, you can all watch it on YouTube. This is how it looks. But I want to give the online audience a chance to see all of you. So if you will indulge me, I'm going to use this iPad to turn the camera on all of you. Let me get it in. And then on my cue, you're going to say, hello, everyone online, okay? All right. Ready to get the camera ready? Oops, it showed me. That's not what I wanted. Let's put on that camera. There we go. All right. So it's showing all of you now. All right. Ready for the cue? Say hello, online audience. And the online audience will all jump in the chat and say hello to us. One more time. Hello, online. Hello, online. Thank you so very much. We need to get them involved for sure, right? I found the presentation excellent. I'm sure you will all agree. Another round of applause if you do. And when you had your slides, I was trying to figure out, because pain can affect movement, if I could touch my, what's that song? Head, shoulders, knees, and toes. All right? So let me see you stand up. Everyone, we're going to take it nice and easy. Doc says we must work into it. We mustn't go too far. Yes? Auntie, I'm going to see you stand up. Caleb, you can stand up too. Mr. Philpotts Brown, yes? Okay. Yes, Claudette, okay. So, we were told that light to moderate exercise is good, yes? And we should always do it. So we're going to do something simple. We're going to touch our head. We're going to pray that there's no pain in our head. And then is it shoulders? Yes? And then it is knees. All right, let's see how far we can go now. And then toes. Maybe you have to do it like this because you can't go down. That could be me. Thank you so much, everyone. I really appreciate your participation and getting involved. Dr. Davis, we've said thank you many, many times, but there are more thanks to give. So at this point, I'm going to invite Mrs. Nola Philpotts Brown to come on up and give the official vote of thanks before we wrap up this evening's proceedings. Please make her welcome.
Thank you, Carly. Thank you, our dear moderator. Our moderator said that that in her opening remarks, she said that we should all look forward to a memorable and remarkable presentation. I would hasten to add, Carlette, that this has been an identifiable and relatable presentation. So I'm going... Relatable because many of us can admit to having some of this pain, right? Identifiable because many of us also can recognize some of these symptoms. And we can even recognize some of the medications. So it is therefore a rewarding task for me on your behalf to say a huge thank you to Dr. Davis for this presentation, and we invite you to give her a round of applause. Dr. Davis, thank you so much. I was looking forward to this presentation because I have personal experiences of pain, persons in pain around me. And so that is why I put those two words, identifiable and relatable. We want to also thank Father Archdeacon Patrick Cunningham Donna Bennett and the team for behind the scenes working to make sure this happened this evening. Let's give them a round of applause, please. Father Kamar, thank you so much for blessing us and inviting the presence of God to direct the proceedings. Christine gave us a beautiful rendition, and we have to applaud her in her absence, right? Come on, let's do better than that. We had a wonderful presentation this evening from Christine. And of course, let us just add to that Anne-Marie Yuan's presentation. Anne-Marie, I'm sorry. You gave away yourself. From now on, you will be a regular. So, you know, just look out, look out. Mrs. Christine McDonald Nevers, she introduced, Mrs. Patricia Donald Phillips. She introduced a speaker for us this evening. Mrs., where did she go? She there, okay. Well, I want to thank her. Very eloquent introduction, and you could tell that she knew you very well. So we thank her for coming and for introducing you to us. Of course, our moderator, Carlette, please give her a rousing round of applause for keeping us energized, keeping us interested in the presentation this evening. And then I'll just swing back to Dr. Davis. It was a remarkable presentation indeed. And we're looking forward to having you back. Hopefully, we have a lot of persons. The St. Luke's congregation is an aging congregation, and so many of us are going through a lot of the things that you spoke about, the different types of pain and the medications that we have to take and so on. And so we really do look forward to having you. And you may very well have some patients as well very soon. So look out for that. Thank you all so much for coming this evening to this lecture series for Health Month. We really do look forward to having these lectures each year, and each year brings new perspective, as our moderator told you. So thank you once again. Have a great evening, and we're going to, I think, I'm going to hand you over to our moderator who will take you from there. Thank you. From here. Thanks.
Thank you, Nola. This is a man that's always asking us to give and give and give more, because God loves a cheerful giver. But I'm going to ask him to give tonight. Dave, if you could please join us right here. I would like for you to do a presentation for us. So you're going to stand here, right here. All right? And everybody who has a camera on their phone, time to take it out. And Nola, you're doing so well. Yes, no, give it to Dave, please. Yes. Dr. Davis, I would like for you to stand right here. Yes. Yes, yes. And I know Mr. Caleb Dixon there is also going to get it on the video camera, but please, if you'd be so kind to make that presentation, and I'm also going to take pictures. Thank you so very much, Dr. Hold on. See how women see these things? I'm going to just, yes, there you go. Can never depend on a man. Yes.
Check, check. All right. And the thanks have been said, but I just want to add my own thanks and really appreciate the presentation this evening. Really informative, really well put together. I'm not yet suffering from all these pains that they speak of, but I guess this is what I have to look forward to possibly, or try to figure out what I need to do to be preventative. So you might be seeing me sooner than later. But really, thank you again so much, and it's on behalf of the rector and the congregation here at St. Luke's, you know, just want to present you with this token of our appreciation. Thank you so much. All right.
Thank you. Well done. Thank you so very much. Yes. All right. Ladies and gentlemen, it has been certainly full and fruitful. Before we go, I would like to just thank you myself for your attention and your participation. I'm quite grateful. I'll take a moment to say how much I enjoy being a part of this church and being with all of you Father Pat met me at a very difficult time, and he has been remarkable. And he and everyone in this church has been so supportive. Thank you so very much. I was trying to find a Bible verse to encapsulate all of this, and I found Psalm 30, verse 5, which says, "Weeping may stay for the night, but rejoicing comes in the morning." After this session, I'm certainly going to rejoice. My name is Carlette Delian, and I thank you. We are going to close as we started with a prayer from our leader. Ladies and gentlemen, please welcome Archdeacon Patrick Cunningham.
Good evening, friends. I must say, and I hope I won't cause any embarrassment to Dr. Davis, she's my doctor, and I'm proud to say that. And she's a wonderful doctor as well, excellent doctor, and I love her dearly. Please stand for prayer. They that wait upon the Lord shall renew their strength. They shall mount up with wings like eagles. They shall run and not be weary. They shall walk and not faint. Father, we give you thanks for blessing us this evening. And we pray that we may experience your healing power in our lives. Heal us from the many pains that we experience from time to time. And where we can't experience that healing, we pray that you'll give us the strength to endure and give us patience in our endurance. And the grace of our Lord and Savior Jesus Christ, the love of God, and the fellowship of the Holy Spirit be with you all, now and forevermore. Amen. And we pray God's blessing upon the refreshment that we shall partake in the church hall. Pray that God will bless it to our bodies and us for his service, for Christ's sake. Amen. Have a good night and a safe journey home. Join us for refreshment in the church hall, please.